Hello, I'm Dr. Christine Browning, Professor of Counseling at Milligan University. Welcome to a mini lecture on the evidence and effects of childhood trauma and abuse. We'll be looking at these objectives throughout this presentation: trauma through the eyes of a child, the evidence of childhood trauma and abuse, the ongoing effects of childhood trauma and abuse, healing that's possible, and assessment and treatment of childhood trauma and abuse. I think stories are powerful. They contain the connection with emotion that brings clarity and understanding to a complex topic. I offer you this story from my childhood as an example of a child's processing of trauma in the moment and a brief view of how it still impacts me today. All stories of trauma are sacred. They are not easily written or shared. They come with a cost to the reader, writer. I invite you to hold my story tenderly. Some of my earliest memories of my brother Bill include how much we enjoyed playing together. On one particular evening, while my mother and father were attending an FBI function and my sister Mary Jane was babysitting, Bill 2 and I 6 were engaged in a game of chase. I can still hear Bill's squeals of delight as we gleefully run down the hall, through the kitchen, and around the dining room table. On one of our trips around the table, Bill's foot catches on a chair leg, and he goes down hard, his nose hitting the low metal-encased windowsill. Blood gushes from his face, and his squeals of delight contort into screams of agony and surprise. I crouch under the dining room table, longing to be invisible. I see Bill's blood-covered face and freeze. Mary Jane is suddenly crouched under Bill, wiping his face. Crouched over Bill, wiping his face. More than all the emotions swirling inside me, a dark terror hovers just out of reach. I'm more terrified of what Mother will do about the bloody mess than anything else I might encounter. My entire body seizes with terror as I recall what happens when I make Mother angry. I disappear, ears roaring, mind numbing, body curled into a ball. I'm on my butt with knees drawn into my chest, feet on the floor, head on my knees, arms tightly wrapped around my legs, trying to be as small and insignificant as possible, as if letting go of any part of that terror-born position will cause my body to fly apart. When I hear the ambulance outside, my desire to see my brother is greater than my desire to stay hidden under the table. I feel the cool night air of fall embrace me as I run into the street after the ambulance, screaming, "I killed my brother! I killed my brother!" My body relaxes slightly as I feel a tender embrace and the kind words from my neighbor, Lois, as she softly whispers, "You didn't kill your brother, honey. You didn't kill your brother." My heart rate slows as her words pour over my trembling 6-year-old self. Bill came home from the hospital 6 days later with a diagnosis of retinitis pigmentosa, RP, a genetic disorder. RP results in legal blindness, among other things. A phrase Mother repeated almost daily, "RP is carried by the mother, only appears in boys, and skips generations," still lingers in my memory. I was confused about all the sadness that surrounded Bill's return home because he was alive, although he looked pitiful with a red and blue track of stitches that danced across his perfect little nose, his blue eyes black and swollen from the fall. After Bill's fall, Mother always introduced me as Chrissy, the one who hurt Bill. Until I was late into my teen years, I thought I caused my brother's disability. When my youngest brother John received the same diagnosis at age 5, my confusion compounded. Had I somehow caused his disability as well? I remember Mother screaming at me when John was very small. "What are you trying to do? Kill him?" My confusion lingered and clouded every interaction I had with my brothers. I was afraid to get too close to them for fear I would hurt them more. I was very aware of how disappointed my mother was with my very existence, and how dangerous it was for others to interact with me. I was dangerous. When we consider childhood trauma and abuse, it's important to view it through the eyes of the traumatized child. Dr. Dan Allender, who teaches extensively on childhood trauma and abuse, says, "All memory is fiction." This simply means that when we recall stories of our childhood or any significant memory, we are remembering it from our point of view, at the time we experienced it, in the state of mind we were in at the time, and with limited access to exact facts. None of us have the exact facts. We have our memory, which is flawed. Memories come to us in snapshots. They are not linear. The earliest relationship a child has is with a parent or guardian responsible for keeping them safe, fed, clothed, and protected from physical, sexual, and emotional harm. Adam Young describes 6 things every child needs from a caregiver or parent. He refers to these as the Big 6, and how the presence or absence of these 6 things affect attachment. The following enumerated items are taken directly from resources available on Adam Young's website, www.adamyoungcounseling.com. The first, attunement. Were your parents so attuned to you that they knew what you were feeling? A parent distracted by their own needs, wants, emotions, and personal pain cannot be attuned to the child's needs. 2, responsiveness. When you were distressed, mad, sad, afraid, did your parents respond to you? Did they offer comfort, care, and kindness? Number 3, engagement. Did your parents have an internal intention and desire to truly know you, to know your heart? Were they willing and able to engage you on a heart level? Were you pursued by your parents? Number 4, ability to regulate your arousal. Arousal refers to the bodily sensations we feel inside of Arousal refers to the bodily sensations you feel inside of you during moments of distress. If your mother was attuned enough to you and willing to respond to you and engage with you, then she was able to effectively regulate your arousal. In other words, she was able to soothe you when you were anxious or scared, and stimulate you when you were shutting down. As an infant, you had absolutely no ability to regulate your own arousal. However, if your mother was able to regulate your arousal, then she enabled you to learn how to regulate your own arousal, to calm your own anxiety, and spring to life again when you are going numb. A child cannot regulate his or her own arousal. The child is utterly dependent on their mother's ability to regulate it for them. Strong enough to handle your negative emotions, number 5. Did your parents welcome your anger, sadness, and fear. As a child, you needed to be free to express negative emotions, to cry, rage, or fall silent, knowing that you would be responded to in a loving, meaningful way. You needed to know deep down that your emotions were accepted and allowed. Number 6, willing to repair. When your parents hurt you, did they own and rectify the harm done? A healthy, trusting attachment is not built on the absence of failure, but on the willingness of a parent to own and rectify failures when they do occur. No parent gets it right 100% of the time. Parents get tired, distracted, and frustrated. They get stressed out trying to do 100 things at once. There are times when even the best parents are not attuned or responsive. What mattered to you as a child was not that your parents got it right each time, but that they recognized when they missed you or hurt you and responded in a way that brought comfort and connection. The ACEs questionnaire is available online and contains 10 questions that relate to early childhood experience that are traumatic. They relate to early childhood experiences that are traumatic. The higher your ACE score, the more at risk you are for negative health outcomes. The CDC's Childhood Experiences Study, the CDC's Childhood Experiences Study uncovered a stunning link between childhood trauma and the chronic diseases people develop as adults, as well as social and emotional problems. This includes heart disease, lung cancer, diabetes, and many autoimmune diseases, as well as depression, violence, being a victim of violence, and suicide. The first research results were published in 1998, followed by 57 other publications through 2011. These results showed that childhood trauma was very common, even among employed, white middle-class, college-educated people with great health insurance. There was a direct link between childhood trauma and adult onset of chronic disease, as well as depression, suicide, being violent, and a victim of violence. The more types of trauma reported, the more increased the risk of health, social, and emotional problems. People usually experience more than one type of trauma. Rarely is it only sexual, physical, or verbal abuse. It's more likely a combination. A whopping 2/3 of the 17,000 people in the ACE study had an ACE score of at least 1. 87% of those had more than 1. 18 states have done their own ACE surveys. Their results are similar to the CDC's ACE study. And you can see by this schematic that the higher the trauma impact, the higher the trauma experiences, the more impact there is on early disease, death, risky behavior, multiple things. The brain has 3 parts. So if I could get you to look at the brain, if you would take your hand, put your thumb in the middle, wrap your fingers around it. This is the reptilian or primitive brain. And I'm starting at the bottom. This is the brainstem. It's the basic housing. It's responsible for arousal, sleep-wake, hunger satiation, breathing, chemical balance. This is the part of the brain that gets the message, gets alerted to danger, and responds with a fight, flight, or freeze response. The next part of the brain to get the message is the emotional brain, the limbic brain or mammalian brain. It holds the map of the relation between the organism, me, and the surrounding or the context. It is responsible for emotional relevance, categorization, and perception. And perception. The last part of the brain to get the message of danger is the neocortex or cerebrum. This part of the brain is the prefrontal cortex. It's responsible for planning, anticipation, sense of time and context, inhibition of inappropriate actions, and empathic understanding. Now, if you think about me when Bill fell and I was hiding under that table, this is what got triggered, and I froze. I froze under that table. Part of that freezing was a dissociation response of ears roaring and no words. That entered then this limbic or mammalian brain, the emotional brain, that shot off all kinds of chemicals in my brain, increasing my heart rate, keeping me in that freeze state, taking my words away. There were no words, no way I could talk or explain what was happening to me. And then the last thing to get the message that I was going to be okay was the frontal part of my brain, the part of my brain that is responsible for appropriate responses, the planning, understanding, empathic understanding. So the ability to be kind to myself with what was happening. When a traumatic memory is triggered, the reptilian brain jumps to attention and responds with a fight, flight, or freeze response. Next, the emotional midbrain gets the message and releases stress hormones, cortisol, norepinephrine, and adrenaline, to help the brain's sympathetic nervous system respond to the threat. The last part of the brain to get the message is the frontal lobe, the place where planning and reason reside. Imagine a child who comes to school with little sleep because she's been up all night trying to protect herself and possibly smaller siblings from abusive parents. With little sleep, she puts her head on the desk but can't rest. Someone drops a book and she jumps. She's triggered by the loud sound. She bolts up, tries to run out of the room, running into and pushing a classmate over in the process. Asked to explain what happened, she can't tell you. She says she doesn't know, which is the truth. Children who've experienced trauma and abuse have a pervasive pattern of dysregulation, problems with attention and concentration, and difficulties with getting along with themselves and others. These children's moods and feelings rapidly shift from one extreme to the other, from temper tantrums and panic to detachment, flatness, and dissociation. When they get upset, which is much of the time, they can neither calm themselves down nor describe what they're feeling. Additionally, when something triggers memory of a trauma, Broca's area, the part of the brain responsible for producing speech, goes offline. This is known as alexithymia, similar to what happens as a result of a stroke by which Broca's area is affected. The individual literally has no words. They cannot put thoughts and feelings into words. Even years later, traumatized individuals have enormous difficulty explaining what has happened to them. Bodies re-experience terror, rage, and helplessness, as well as the impulse to fight, flee, or freeze, as if they are in the moment of the original trauma. But these feelings are impossible to articulate. In my early 40s, sitting in a graduate course on exceptional children, I was triggered with a memory of Bill and encountered the open wound of terror, shame, and confusion I felt when Bill fell. The repeated introduction of "This is Chrissy, the one who hurt Bill," rang in my ears. I later realized that the fear of damaging others had attached itself to my relationships with my brothers and held me back from additional close relationships I longed for. Fresh grief over years of missed opportunities to bond more closely with my brothers rushed to the surface, as well as accusations of how dangerous it was to be close to me. I viewed my desire for relationship with others as a real threat to their well-being. The message was clear. Being near me was dangerous. I was dangerous. Basil van der Kolk, who wrote The Body Keeps the Score, talks about 3 ways to process trauma. The first is top-down, or by talking. If you think of children, they don't really have words to tell you. They really relate their stories more through play. And as we just talked about, if the speech center is offline, if alexithymia is happening, there are no words. The person cannot describe to you what's happening. So top down is not necessarily a good way to process trauma. A second way is medication. Now, let me be sure that you hear this. Medication is often necessary and needs to accompany proper therapy. But sometimes medication is used as an excuse to dull the symptoms, and it never really gets to the root of the trauma. Bottom-up processing allows the body to have experiences that deeply and viscerally contradict the helplessness, rage, or collapse that result from trauma. So as I remember this story of Bill, and someone sits with me and does not blame me, does not say, "You're the one who hurt Bill," but responds to me with respect and compassion and sits with me if there are tears or shaking or rage, that gives me a different ending to the story I knew, and that helps start me on a path toward healing. Children with histories of trauma and abuse show up in clinics, schools, hospitals, and police stations. The traumatic roots of their behavior are not obvious or considered. They rarely talk about having been hit, abandoned, or molested, even when asked. They develop physical problems, sleep disturbance, headaches, unexplained pain, oversensitivity to touch or sound. Frequent agitation or dissociation makes it impossible to focus, attend, and concentrate. To relieve tension, they often engage in chronic masturbation, rocking, self-harming activities such as biting, cutting, burning, and hitting themselves, pulling out their hair, picking their skin until it bleeds. They have difficulty with language processing and fine motor coordination. They spend all their energy trying to stay in control. They have trouble paying attention to schoolwork or things not directly relevant to survival. Hyperarousal makes them easily distracted. Being frequently abandoned or ignored makes them clingy and needy. Chronically beaten, molested, and otherwise mistreated, they see themselves as defective and worthless. The combination of feeling fundamentally despicable and overreacting to slight frustrations makes it difficult for them to make friends. These children are labeled with diagnoses such as oppositional defiant disorder, disruptive mood dysregulation disorder, attention deficit hyperactivity disorder, reactive attachment disorder. They typically accumulate numerous diagnoses over time. Before they reach their 20s, many children who've experienced ongoing trauma and abuse receive 4, 5, 6, or more diagnoses that name symptoms but never uncover or even consider the underlying trauma and abuse at its root. If they receive treatment, it's usually the most popular therapy fad: behavior modification, exposure therapy, medications. Again, hear that medications are sometimes necessary. These rarely work and may even cause more damage. Looking back at my story, I see my tension and hesitation to be vulnerable with others still play out in my relationships and interactions. I fear disappointing authority figures. I also fear my presence will cause irrevocable harm to those with whom I interact, as well as those I love. This behavior presents in different ways, and is a result of the multiple traumas I experienced and the need to address the core traumas and terror surrounding them in order to continue to learn new healthy ways to relate and form new neural pathways in a brain altered by trauma and abuse. Thankfully, healing is possible. But it takes time, commitment to the process, and a willingness to go back into dark memories. It's a journey that requires a guide with knowledge of the delicacy of the process, respect and compassion for the client, and a willingness to sit in the messy aftermath of the trauma and abuse with the client, sometimes with no more than your presence and honor for their rage, tears, confusion, and deep, deep grief. Martin Teacher, MD and PhD, said in Scientific America, quote, "Early maltreatment has enduring negative effects on brain development. Our brains are sculpted by early experiences. Maltreatment is a chisel that shapes a brain to contend with strife, but at the cost of deep, enduring wounds. Childhood abuse isn't something you get over. It is an evil that we must acknowledge and confront if we aim to do anything about the unchecked cycle of violence in this country." Basil van der Kolk in The Body Keeps the Score highlights several effective treatment options for children, adolescents, and adults who have experienced traumatic and abusive early childhood experiences. The treatments are varied and provide the counselor with the means to adapt the treatment to the child's particular needs. There are core components necessary to these interventions. You see those on the screen. More core components. Additional core components. In contrast, interventions that do not include the needed core components may be inappropriate for the population or may require substantial adaptation. Effective treatment options listed here. These options are expanded on in Basil van der Kolk's book, The Body Keeps the Score. I highly recommend that reading. In closing, the need for effective treatment and intervention is paramount. Experts in the field believe childhood trauma and abuse is the largest threat to well-being. Students at Milligan University have access to learning how to work with children, adolescents, and adults who've experienced trauma and abuse. Check out our Master of Science in Counseling program by accessing Milligan's homepage, then Academics, and Graduate Programs. Or contact our recruiter, Stacy Schenkel, at srschenkel@milligan.edu. And you can contact me at cmbrowning@milligan.edu. References to the resources I used for this presentation are listed here, as well as some resources you can use for intervention. These are also listed in Basil van der Kolk's book. Thank you so much for attending this mini lecture. God bless you.